Okay, so good evening, ladies and gentlemen. We would be talking about thick-walled ventricles, the role of echo in differential diagnosis. As you know, hypertrophy actually means increase in left ventricle mass, and that may be there without increase in wall thickness. So today's topic is primarily about thick-walled ventricles and their differential diagnosis. Before I start the presentation, let me just show you a parasternal long axis view of a young boy whom I saw just few months back. He's a 12th class student who actually had a sudden cardiac arrest in his school at 8 a.m. in the morning. He was revived and was sent to me. Look at this parasternal long axis view. What is striking is that the anterior interventricular septum, anterior interventricular septum is markedly thick. It's close to 4 centimeter in diastole thickness. And of course, the infralateral wall, just opposite that, is probably normal in thickness. So you know, of course, that this patient has what we would call it hypertrophic cardiomyopathy. The characteristics here are asymmetric septal hypertrophy. The septum is at least 3 times of the thickness of the posterior wall. You also see the convexity of the septum towards the left ventricular cavity. You note some thickening of the anterior mitral leaflet, and you also note long anterior mitral and long cords of the mitral valve. So this is a classic case of non-obstructive hypertrophic cardiomyopathy, and of course you can induce or you can provoke a gradient to find out whether provocable gradient is there or not. So in this boy, we scanned his sister, who's an air hostess. She was found to have similar features, and his older brother, who had absolutely similar features. So this is an individual who has hypertrophic cardiomyopathy with a history, with a typical history convex appearance. Now, when I take you further, I will tell you what is the meaning of this picture by echo. But in short, such people have genotype which is positive for one of the sarcomeric proteins. Family history is available, and these people are at a risk of sudden cardiac death. Let me show you another picture before we come to this main topic. And this is a 34 years male with dyspnea. Now, look at this 4-chamber view carefully and look at the distal half of the left ventricular cavity. Apparently, there is increased wall thickness in mid segments. But if you look carefully, it is not the muscle which is thick. These are all big trabeculations. You'll be surprised to know that this kind of pseudo-hypertrophy as a result of big trabeculations can also be detected in hypertrophic cardiomyopathy sarcomere gene mutation carriers without evidence of hypertrophy. So this gentleman also is a case of hypertrophic cardiomyopathy, but a completely different variety, Here, it is not the muscle thickness, and you probably would think that this is more like a non-compaction of the left ventricle. There is an overlap between non-compaction of left ventricle and hypertrophic cardiomyopathy. There can be a common sarcomeric protein gene variation which could account for the two. Okay, so we are talking about the issue of thick-walled ventricle and not increased left ventricle mass. As I said, wall thickness more than 12 millimeter in diastole is considered to be thick. Usually when we talk about, we are talking about 15 millimeter or more. Remember, between 13 and 16 millimeter, this is a gray zone which can occur in many athletes, physiologically very active people, sometimes with mask hypertension and sometimes with big individuals who have a big body surface area. How do we measure the wall thickness? There is a short axis view, the pathology specimen, and of course lower down short axis view. You obviously are not going to measure trabecula. You're not going to measure endocardium. You start from the trailing end of the endocardium and go to the leading edge of the epicardium. That is what is called wall thickness in diastole. So all ventricular walls should be analyzed at multiple levels, but measurements have to be done in end diastole, preferably in short axis view, and by the method I described, which is the ASC recommended method. When you find that the left ventricular wall is thick, you need to note 5 points. Is that wall thickness focal or diffuse? Is it segmental or generalized? Is it true or false? I showed you an example of a false hypertrophy, the second case. Is it asymmetric or concentric? That means all walls are equally thickened or one wall is much more thickened than the other wall. Is there an obstruction or it is non-obstructive? And we will show you examples of that. And of course, you have to carefully look for mitral valve abnormalities, which are present in 50% cases of hypertrophic cardiomyopathy, which after hypertension is the second most important entity having thick walls, thick-walled ventricle. From our viewpoint, left ventricle thick wall or hypertrophy is two types. Concentric hypertrophy, where left ventricle mass is increased, but the wall thickness the relative wall thickness exceeds 42%. You have another variety, eccentric hypertrophy, where the relative wall thickness is less than 42%. However, the left ventricle mass is increased, gender-specific left ventricle mass is increased. That is because of increase in left ventricular cavity size. And that's called eccentric hypertrophy, common in athletes, common in mitral regurgitation, aortic regurgitation, so on and so forth. There are two more terms which are used, one more term besides the concentric hypertrophy called concentric remodeling. Concentric remodeling also has relative wall thickness more than 42%. And remember here, some people have taken the takeoff as 45%, but be as it is. The concentric remodeling characterized by normal left ventricle mass index, but increased wall thickness. Concentric hypertrophy has increased left ventricle mass and increased wall thickness, while concentric remodeling has only increased ventricle wall thickness with normal left ventricle mass. So let us discuss the differential diagnosis of thick-walled ventricle. There is no doubt that there are some conditions which cause what is called borderline thick-walled ventricle or mildly thick-walled ventricle, like diabetes per se, CKD, and of course aortic stenosis causes big thick-walled ventricle and coronary artery disease. But when we talk of differential diagnosis, we are talking about athlete's heart, hypertensive heart disease or hypertensive left ventricle hypertrophy, hypertrophic cardiomyopathy, infiltrative cardiomyopathies, endocrinopathies like acromegaly, hypothyroidism, and of course, sometimes the regional wall thickness can be because of mural hematoma, mural tumors, and mural cysts. And don't forget, pseudohypertrophy can be present not only in myocarditis and immediately following acute myocardial infarction due to reperfusion injury, but also you can have a non-compaction of the left ventricle. Infiltrative cardiomyopathy, we all should remember, amyloidosis is the top. The other conditions are Anderson-Fabry disease, hemochromatosis, hereditary oxalosis, Friedreich's ataxia, Dannon's disease with skeletal myopathy, and mucopolysaccharidosis, and glycogen storage disease. When you talk of hypertension, which is the commonest issue, note that in a patient with left ventricle in a patient with hypertension, everything is possible. Person may have normal left ventricle mass and normal relative wall thickness. The left lower rectangle. You can have increased relative wall thickness with normal left ventricle mass, concentric remodeling, the left upper corner. The right upper corner is increased left ventricle mass and increased relative wall thickness, typical left ventricle hypertrophy. And of course, you can have eccentric hypertrophy also in arterial hypertension. So arterial hypertension can have all four varieties. Whenever you see left ventricle hypertrophy and you suspect it is hypertensive heart, usually the wall thickness does not exceed 16 millimeter. Occasionally it can be so. Check for blood pressure, and if you suspect mask hypertension, do an ABPM. Find out the history of use of antihypertensive drugs, body mass index, because if that increases, sometimes you can get concentric hypertrophy. And of course, type 2 diabetes history, because they can also present with wall thickness. So here is an example of an individual with the hypertension and left ventricle hypertrophy. Although there is still asymmetric septal hypertrophy, which is not uncommon in hypertension, there is no systolic anterior motion of the mitral valve, normal mitral valve, and normal septal curvature. You'll call it neutral septal curvature. Classically, that kind of thing is, and the wall thickness rarely exceeds 16, 17 millimeter, although there are exceptions. Typically, if you want to differentiate it from hypertrophic cardiomyopathy, left ventricle hypertrophy and hypertension never exceeds 25 millimeter. The other reasons for that kind of hypertension can be aortic stenosis, coarctation, subaortic membrane, and so on and so forth. One of the other conditions where the hypertrophy can be actually more than what you get in hypertension is pheochromocytoma, because catecholamines are actually strong growth factors, big growth factors. And this is a young lady with pheochromocytoma, and you see concentric left ventricle hypertrophy, very thick walls, and the wall thickness actually is about 22 millimeter both. No asymmetric septal hypertrophy, no SAM. Mitral valve may be slightly thickened. It is known actually in pheochromocytoma sometimes, but this is another variety which you should keep in mind. Whenever you find that somebody has episodic hypertension, but much thicker walls, think of pheochromocytoma. The other condition which has similar kind of walls with and without hypertension is acromegaly. So the acromegaly you wouldn't miss if you look at the face of the individual. You can also have this kind of picture in CKD with normotensive individuals, also in hypothyroidism. But hypothyroidism does not produce that much wall thickness, although from 12 to 16 millimeter wall thickness is not uncommon in pure hypothyroidism. We'll talk about hypertrophic cardiomyopathy. Nearly 50% are genotype positive, which means they have mutation of a sarcomeric protein, and 50% are genotype negative. In both conditions, you can have typical phenotype and you may not have typical echo features. So echo features can be present with genotype negative hypertrophic cardiomyopathy as well as genotype positive cardiomyopathy. Hypertrophic cardiomyopathy, now the story is nearly 60 years old. It's also called Thierry syndrome because Thierry described a young man with hypertension and tumor-like hypertrophy of the left ventricle in 1958. Genotype positive, phenotype negative, asymptomatic patients include elongation of mitral valve and late gadolinium enhancement, and hence in family history or wherever genotyping has been done, carefully look at the mitral valve and echo, and of course late gadolinium enhancement showing fibrosis or positivity at the two attachment points of the interventricular septum. There are hundreds and hundreds of sarcomeric protein mutations which are blamed for hypertrophic cardiomyopathy. The major ones are myosin heavy chain mutation, myosin light chain mutation, myosin binding protein C, troponin complex, tropomycin, actin, and there are many more actually, which we need not actually go. As clinicians, we are not geneticists. We don't have to remember all the 127 or 174 mutations, but remember, this is a job of a geneticist to find out which type of mutation is there. Why it is important? Because each mutation may have a different phenotype and a different prognosis. Finally, you have to remember, when we talk of hypertensive left ventricular hypertrophy and hypertrophic cardiomyopathy, tissue is the issue. Tissue is the issue. And it is the myocardial fiber disarray and more fibrosis, which is present in hypertrophic cardiomyopathy and in hypertensive left ventricular the myofibrosis may be there. However, the disarray or fiber disarray is very little. So you have myofiber hypertrophy, which is common for hypertension as well as hypertrophic cardiomyopathy, myofiber disarray and fibrosis, which is much more marked in hypertrophic cardiomyopathy. And because of that reason, people have used E prime, S prime, and GLS to differentiate hypertensive heart disease from hypertrophic cardiomyopathy with reasonable sensitivity and specificity. So hypertrophic cardiomyopathy, let us summarize: 50% genotype positive, autosomal dominant, attachment point LGE positivity, diffuse defect on T1 mapping more because of extracellular matrix, more in the septum, and of course echocardiographic phenotypes. Let's come to echocardiographic phenotypes. Before we come to echocardiographic phenotypes, remember there's a marked genotype heterogeneity in hypertrophic cardiomyopathy. There is marked phenotype heterogeneity, and there's a marked clinical heterogeneity. So the first classification, phenotype classification, was given by Barry Maron in 1981. This is a 40 years old classification. Type 1, only basal part of the septum is involved. It's called sigmoid septum. Type 2, entire septum is involved. Type 3, septum plus antrovall show hypertrophy. And type 4 was apical hypertrophy. Remember, we are talking 40 years back. These were the 4 types. Let me show you an example. First, a type 1 example, sigmoid septum. You can see the convexity of the basal anterior septum. You can see SAM. You can see elongated anterior mitral leaflet, posterior leaflet, as well as cords. Sigmoid, the type 1, actually the genotype positivity is less than 10%, close to 10%. But it is type 1 hypertrophic cardiomyopathy, relatively uncommon. This sigmoid septum is this may be sub-express hypertrophic cardiomyopathy, but type 1 can also be different, has to be differentiated from aging phenomenon and angle alteration due to root enlargement. So whenever you find SAM or you find mitral valve abnormality, think of hypertrophic cardiomyopathy rather than aging phenomenon. Sigmoid septum as such is present in 6% of all undergoing echo, usually very elderly people, and resting gradient is almost seen in, not seen in 97%. Mean wall thickness about 18 millimeter, and they know family history. These are the characteristics of type 1 hypertrophic cardiomyopathy of Maron's. Type 2 hypertrophic cardiomyopathy involves the entire interventricular septum. Here is contrast study in a 4-chamber view, and you can note that the entire interventricular septum is thickened right up to the apex, starting from the aortic valve up to the apex. This is type 2, Maron's type 2 hypertrophic cardiomyopathy involving only the septum. For comparison, you have the anterolateral wall, which is normal in thickness, although the papillary muscle is somewhat thickened. Type 3 Maron's classification, both septum and anterolateral wall are hypertrophied, as you see here, and that would include all the segments. In addition, when I'm showing on right side the longitudinal strain, you'll realize that the septum has paradoxical strain, which means septum shows stretching during systole. And we'll talk about paradoxical IVS strain later on and its value in diagnosing hypertrophic cardiomyopathy. Asymmetric septal hypertrophy, which is common in hypertrophic cardiomyopathy, can also be present in hypertensive left ventricular hypertrophy, sigmoid septum or septal knuckle, amyloid Pompe's or Fabry's disease. It is not exclusive for hypertrophic cardiomyopathy. This is the fourth type 4 variety of Maron's classification, apical hypertrophic cardiomyopathy. This is a friend of mine, a pulmonologist, who has, of course, this typical T-wave inversions, V2, V3, V4, V5, V6, and typical apical hypertrophy, relatively asymptomatic. The genotype is positive. Apical hypertrophy is genotype positive only in 30%. We will continue with the type 4 of Maron's classification. This is another type 4 of Maron's classification. This not only is involving the septum, but some part of the mid septum also. It could be a variant, actually, a variant of type 4, or you could call it apical hypertrophy because the distal half or apical half of the septum is hypertrophied. But note also the abnormalities of the mitral valve. Anterior papillary muscle, anterolateral papillary muscle is more anteriorly placed, projecting into the cavity, and also the cords are long. Although Maron didn't describe, but we quite often see another variety called, it is reverse 4. That means reverse of apical hypertrophic cardiomyopathy. This is an example where apex is spared, but the anterolateral wall and septum, both in basal segment and mid segment, show significant hypertrophy, long cords, abnormal papillary muscle, and of course abnormal anterior mitral leaflet. This variety is also very rare. Although not mentioned in the literature, we have found it present in about 1%. We are supposed to be reporting it. We haven't reported so far. The pattern, in fact, somebody has modified that classification by Maron and said that you can have septal hypertrophy alone which is called pattern 1, septal and adjacent segments pattern 2, apical hypertrophy in combination with other segments pattern 3, and apical hypertrophy alone as the pattern 4. So there is another classification also, but there is another classification called Wigle's phenotype, which we quite often use. It has subaortic obstruction, so-called IHSS, mid-cavity obstruction, and cavity obstruction. So let me show you a classic case which we said hypertrophic, which was called initially by Brock as idiopathic hypertrophic subaortic stenosis. Here you can see asymmetric septal hypertrophy, SAM, narrow left ventricular outflow tract, and there are gradients. And this individual is what is Wigle's type 1. So if I show you the M mode, you will see asymmetric septal hypertrophy, and of course you can see SAM, which is seen here carefully. Okay. This is an 18-year-old boy, again showing the same features, type 1 of Wigle's, that is subaortic stenosis, hypertrophy of the interventricular septum, but note the abnormalities of the cords, pap muscle, and anterior mitral leaflet. This is what you call reverse curvature or convex curvature of the interventricular septum. 90% of these, not 90, 80% of these are genotype positive. The mid-cavity obstruction, this is the most classic I have ever seen. Huge big aneurysm at the apex and mid-cavity which is almost obliterated. Such things are not that common, but I would show you some more examples of mid-cavity obstruction. The third variety of Wigle is what is called obliterated cavity variety, and this is a lady from West Bengal. She is about 55 years, and you note cross thickening of the walls and the left ventricle cavity is almost obliterated. In systole, definitely obliterated. In diastole, it is much less. This is Wigle's pattern 3, and this is associated usually with pericardial effusion. Mayo, Jamil Tajik and colleagues, and the first author is their fellow Imran Syed, described another classification of hypertrophic cardiomyopathy. They called it, based on the curvature of the septum and hypertrophy involvement, both 5 types. Reverse curvature, genotype 80% positive. Neutral curvature, sigmoid, apical hypertrophic cardiomyopathy, and mid-cavity obstruction. Now, there is some reason for this classification. Neutral curvature and sigmoid genotype positive only in 16%, while apical genotype positive in 30%, and reverse curvature is genotype positive in 80% cases. So this classification seems to be more reasonable for us to use. I wanted to show you mid-cavity obstruction. This is an example of a mid-cavity obstruction, an apical aneurysm, and of course typical lobster claw appearance because of mid-cavity obstruction. And remember, the claw of the lobster actually is present in early and mid part of the diastole. Classic pattern of a lobster claw in mid-cavity obstruction. This is a reverse curvature. Reverse curvature means the curvature of the septum is facing the left ventricle. This is 80% genotype positive, as I told you. And here, of course, not only the other interesting part here is papillary muscle is hypertrophied and abnormally oriented and is a cause for obstruction in the left ventricle outflow tract. This is an example of a neutral septal curvature. The septum is flat, it's not convex. Neutral septal curvature, although the phenotype may be typical, but genotype positivity is present only in small number of cases, close to about 20%. Another example of a type 2 neutral curvature of Jamil Mayo guys, here the septum again is flat. SAM, we need to actually talk about systolic anterior motion. There are plenty of mechanisms of SAM, but usually SAM is because AML and cords are long, these are lax, and usually the anterior papillary muscle is more anteriorly placed and abnormal, and it is no longer because of Venturi phenomena. The drag is something different. However, the SAM is supposed to have a specificity of about 98%. There are other causes of SAM also, and you can have elderly women with LVH and sigmoid septum and hyperdynamic ventricle function who may show SAM, and non-hypertrophic cardiomyopathy SAM occurs in 0.3% population undergoing echo. So SAM is highly specific, but not 100%. We were talking about frequency of genetic mutations, and as I said, reverse curvature has the maximum genotype positivity. Sigmoid septum has the least, neutral has in between, apical has 30%. So the family history is much more common in reverse type. I showed you the first boy who presented with sudden cardiac death. I showed you apical hypertrophic cardiomyopathy in a pulmonologist friend of mine, and plenty of neutral appearance. Sudden cardiac death actually is much more common in reverse type, and I showed you an example. Somebody was revived from sudden cardiac arrest, that boy. There are multiple sarcomere protein mutations, and all you have to remember is that the myosin heavy chain or myosin light chain or myosin binding protein are the commonest ones for reverse curvature. And we wouldn't go any further in this detail. There are some more things which have to be said about mutations. The beta myosin heavy chain mutation present in adolescents, myosin binding protein people do not present until the age of 50 years, and these troponin type actually have more apical hypertrophy, and troponin I have more apical hypertrophy. Troponin T mutation have increased risk of sudden cardiac death. Let us summarize hypertrophic cardiomyopathy versus hypertensive heart disease. Asymmetric septal hypertrophy has 80% sensitivity to diagnose hypertrophic cardiomyopathy. Left ventricle wall thickness above 25, rarely found in a condition other than hypertrophic cardiomyopathy. Dynamic left ventricular obstruction also has a high sensitivity and specificity. Elongated leaflets, abnormal pap muscle, apicoseptal muscle bundles, myocardial crypts, apical aneurysms. Paradoxical longitudinal strain has a specificity close to 100% by Jerome Beck's data, but sensitivity is 57% to diagnose hypertrophic cardiomyopathy. SAM, as I already showed you, has 98% specificity. Mitral valve abnormalities are present in 50% cases. I already described to you the mitral valve abnormalities, and these people usually are those who are genotype positive. Myocardial crypts are narrow blood-filled invaginations within the left ventricle wall. They are not specific for hypertrophic cardiomyopathy, but they are usually present in hypertrophic cardiomyopathy. And usually these people have sarcomeric protein gene mutation. The issue of paradoxical septal strain, and I want you to pay attention to the left lower quadrant. Here, the two segments of the anterolateral wall show paradoxical strain. This paradoxical strain is present in hypertrophic cardiomyopathy, and we will talk about that in a while. There is another rare variety where the infralateral wall shows excessive thickening and all other walls show small amount of thickening. This is a highly symptomatic variety present in 1 to 2% cases of all hypertrophic cardiomyopathy. Unfavorable prognosis of hypertrophic cardiomyopathy seen in those people who have wall thickness more than 30 millimeter, resting gradient more than 30, apical aneurysm, LGE positivity, and left atrial enlargement more than 48 millimeter. We were talking about paradoxical strain. This is work by Jaron Bex and Victoria Delgado, showing that if you show paradoxical strain in one or more segments in a hypertrophic ventricle, it is 54% sensitive and 100% specific for hypertrophic cardiomyopathy. You have to have left ventricle hypertrophy, and then you have to have 1 or 2 segment paradoxical strain. A proportion of athletes also fall in the gray zone, ventricular wall thickness of 13 to 16 millimeter, and this overlaps the phenotype variation of hypertrophic cardiomyopathy. However, the difference between athlete and hypertrophic cardiomyopathy are many. This is one way. Unusual patterns of left ventricular hypertrophy are common in hypertrophic cardiomyopathy. Cavity more than 55 millimeter common in athlete's heart. LA enlargement more common in hypertrophic cardiomyopathy. Bizarre ECG patterns are more common in hypertrophic cardiomyopathy. Abnormal alveolar filling patterns are more common in hypertrophic cardiomyopathy. Female gender more in hypertrophic cardiomyopathy. Reduction in wall thickness with decondition is common in athlete's heart, and family history of hypertrophic cardiomyopathy helps you in differentiating the two. A lot of work has been done. Athlete's heart mostly have eccentric hypertrophy. GLS is only slightly reduced compared to normal. Remember, GLS is reduced in athlete heart, but not as much as in hypertrophic cardiomyopathy. And S and E prime are normal or super normal in athlete heart, while they are markedly reduced in hypertrophic cardiomyopathy and also in amyloidosis. Taking help of Jerome Beck's data, if there is a GLS which is closer to 10% or less, there is a very high sensitivity, specificity, predictive value for telling that this is hypertrophic cardiomyopathy and not hypertensive left ventricle. As a matter of fact, not only the asymmetric septal hypertrophy helps you, but also global longitudinal strain helps you in differentiating. The reference subjects, typically normal people have about 20% global longitudinal strain. Hypertensive individuals have close to 14–15%, and hypertrophic cardiomyopathy have close to 10% or less. We did publish some of our own work when Partho was my fellow, and he published this in Journal of American Society of Echocardiography. I think it's 15 years old. And we showed that if you use the linear mapping of segments, 80% of patients with the hypertrophic cardiomyopathy have paradoxical strain. But if you do focal mapping by 2D strain, then only 45% of them have paradoxical strain. I also want to emphasize that sometimes Doppler pattern, mitral Doppler pattern helps you in deciding which type of hypertrophic cardiomyopathy you are dealing with. This typical triphasic flow is found in thin filament mutation or called actin filament mutation and is classic for that variety. You can also use left atrial strain, especially the booster strain, to differentiate hypertrophic cardiomyopathy, where the booster strain is always positive, while in hypertension and other situations, actually it tends to be much less actually. So SAM specificity 98%, asymmetric specificity 90%, and of course 76% of these people have IVS more than the posterior wall. And GLS less than 10% have 85% sensitivity and 100% specificity. We come to amyloidosis. This is a 44-year-old gentleman with amyloidosis. The walls are thicker, and you note both the infralateral wall and anterior wall is about 15 millimeter thick. Another example, somewhat thickened, about 13, 14 millimeter anterior septum, and all segments, uniform concentric thickening. Uniform thickening is much more common in amyloidosis, and this is a light chain amyloidosis, or also called primary amyloidosis. We need to differentiate amyloidosis from hypertrophic cardiomyopathy and hypertension. But before that, I must say cardiac amyloidosis should be suspected in every patient with heart failure, thick wall ventricle, which are non-dilated. Classic example, these people not only have left ventricle walls which are thickened, but right ventricle walls are thick. Moderate pericardial effusion is common, thick interatrial septum, thick mitral and tricuspid valves, and septal thickness may be more than lateral wall. Now, when you see this kind of thing, and global longitudinal strain is significantly reduced, as much reduced as in hypertrophic cardiomyopathy, but there is preserved strain of the left ventricle apex, which tends to differentiate amyloid from other conditions. As such, the strain is usually in amyloid less than 15%, but this is not very specific. However, cherry on top, or sparing of the apical strain, or the ratio of ejection fraction to global longitudinal strain exceeding 3 or 4 is highly specific for cardiac amyloidosis. Whenever you have global longitudinal strain showing cherry on top, it is very, very sensitive and specific for amyloidosis, but not 100%. So we would see other conditions which will cause this. Let us leave amyloidosis. I would have liked to talk a lot about amyloidosis. We have a large number of cases, but the time doesn't permit. So we'll talk about Anderson-Fabry disease, which is a rare genetic lysosomal storage disease. It's an X-chromosomal inheritance, so means it occurs in men. And of course, there is left ventricle hypertrophy, concentric left ventricle hypertrophy in individuals with a wall thickness up to 16 millimeter. So you understand that where it would fall. And the other thing is abnormal prominent papillary muscles and preserved global ejection fraction, early stage diastolic dysfunction. So it resembles hypertrophic cardiomyopathy. Here is an example, prominent papillary muscle, wall thick in a patient with Anderson-Fabry disease, but it is 80 times less prevalent than hypertrophic cardiomyopathy. However, if you get alpha-galactosidase A level done and those are absent, it is Fabry disease. And if you find an infralateral wall, mid-myocardial scarring, it is classic for Fabry and absolutely non-classic for hypertrophic cardiomyopathy. So here is another example of Fabry's disease, concentric left ventricle hypertrophy and mid-lateral wall LGE positivity. Remember, the ECG in Fabry's disease is more like hypertensive heart disease, not like amyloid, where the voltages are low and there is a pseudo-infarct pattern from V1 to V3 that's commonly found in amyloid called Goldberger triad. Fabry's disease, as I said, is induced by mutation in alpha-galactosidase A gene, and you can correct this problem early in the course by giving this enzyme. And that is how it differs from other varieties. It is purely curable disease, and even in later stage, it is partially reversible. Primary hyperoxaluria is another rare autosomal recessive disease which produces biventricular hypertrophy and the walls are symmetrically thickened. The secondary hyperoxaluria occurs in CKD and is an important cause of left ventricular hypertrophy. There are many syndromic left ventricular hypertrophy in children and adolescents. The time does not permit me to take you through that, but Noonan syndrome, Danon syndrome, Friedreich's ataxia are some of the classic examples of syndromic left ventricular hypertrophy. So, ladies and gentlemen, let me summarize by saying thick-walled ventricle demands respect of a clinician. You should be able to provide clue to the differential diagnosis by doing a good echo and tell the clinician what he or she should be doing next, whether genotype should be done, alpha-galactosidase A level should be checked. CMR, of course, is required in most of these individuals, it helps in differentiation. And history, sometimes ambulatory blood pressure monitoring may pick up mass hypertension. And few also is an important thing which in episodic hypertension you need to remember. Thank you very much.
Thank you very much, sir. Indeed, an excellent presentation. So I'd like to ask Dr. UP Singh, sir, to.
Yeah.
Yes, sir.
Yeah. So now I think this was a superb presentation by sir as usual. So this was nothing exceptional because he always delivers exceptional talks. So there have been a lot of questions. Let me read out a couple of them as I see them. Dr. Shilpa wanted to know that the non-compaction and abnormal trabeculation which you showed, are they different?
No, actually there is an overlap. There is an overlap. You can get pure hypertrophy cardiomyopathy, pure non-compaction, and a combination of the two. And the reason is sarcomeric protein mutation actually may be common for three.
All right. So we have a common genetic background to cause all that. So they wanted to, you to describe again the regional wall, relative wall thickness relative to the LV size.
Okay. All you have to do is measure the posterior wall thickness in end diastole by the method I described, multiply it by 2 and divide it by left ventricular internal dimension in diastole. Let me repeat. Posterior wall thickness in diastole multiplied by 2 divided by left ventricle internal diameter in diastole. If the ratio is more than 0.42, relative wall thickness is increased, although some people have taken 0.45. You can choose one of these criteria. And if the relative wall thickness is increased, this is concentric hypertrophy or concentric remodeling. If the relative wall thickness is less and still mass is more, it is eccentric hypertrophy or a normal ventricle.
Wonderful, sir. There is Dr. Rakesh wants to know, is there any role of stress echo in hypertrophy or, the cardiomyopathy which you've described?
Sometimes some people have used low-grade stress to actually invoke or provoke gradients. Having said that, more than that, I wouldn't say that there is any role. You sometimes can show SAM, but then the specificity of exercise-induced SAM goes down. I strongly would suggest not to put people on a stress in a patient with hypertrophic cardiomyopathy because stress can be arrhythmogenic in hypertrophic cardiomyopathy.
Absolutely. Do we, sir, classify left ventricular hypertrophy into mild, moderate, and severe?
Well, one could do it, although I have not seen any typical classification. You could do it actually. I would say that if you could take a criteria 12 to 15, 15 to 20, 20 to 25, but I have never seen this being used. So I have interacted with a lot of experienced people. When they write Severe concentric hypertrophy, they actually mean wall thickness exceeds 20 millimeter.
Okay, okay. So how do we differentiate that? I think you've already answered non-compaction and apical HCM. People are still interested to know about Fabry's disease. Dr. Sanjeev Bhatt wants to know, I mean, how do we suspect Fabry's once we see a left ventricular hypertrophy?
So if you have an individual who has concentric left ventricular hypertrophy, features of heart failure with preserved ejection fraction, and relatively normal left ventricular ejection fraction, no SAM, no ASH, and no hypertension, you should strongly try to rule out Fabry's disease in these individuals. And remember, this is an autosomal recessive disease. Family history may be available and maybe they're in both. And simple thing is to do an alpha galactosidase A level. It is easily doable, and in case it is absent, it is Anderson-Fabry disease. The next step is to do a cardiac MRI.
Dr. Gautam Sharma wants to know, is there any role of ACE inhibitors? We also thought once we were in PGI that there should be some role of, ACE inhibitor in HCM, hypertrophic cardiomyopathy. Is there any role, sir, now?
So the guidelines say none, but I'm aware of the paper published in Indian Heart Journal from PGI Chandigarh showing detection of left ventricular hypertrophy in hypertrophic cardiomyopathy with the use of ACE inhibitors. I distinctly remember this paper came somewhere 30 years back, if I'm not mistaken.
That is the time when I was doing DM there, sir. I know.
Yeah, 25, 30 years back.
Yeah.
I read this paper very carefully, and Dr. Sethi actually laughed at the paper, but then it is all right. It's okay. At least the proof of concept was there, but nobody has taken it any further.
Yeah. So now the question from Dr. Rohit Kandan, asymptomatic hypertrophic cardiomyopathy versus severe cardiomyopathy. Are there differences on echo? I could not get much of the question. Do you? Asymptomatic hypertrophic cardiomyopathy versus severely symptomatic hypertrophic cardiomyopathy. I think they want to know, is there any symptom and echo correlation? Are there any findings on echo which suggest symptoms that there?
Yeah. So obviously, people who have obliterative variety are markedly symptomatic. People who have gradients, resting gradients are markedly symptomatic. People who have gradients are markedly symptomatic, and people who have obliterative variety are markedly symptomatic. The third variety where the people are symptomatic mid-cavity obstruction.
Correct. Now, there's a question from Dr. Prashant. Can you please explain physiology of LVOT obstruction? I mean, what are the basic causes? Is this pure simple venturi or multiple causes of left ventricle outflow tract or obstruction?
So you know that the hypertrophic cardiomyopathy, initially a lot of work was done by Dr. Prameen Shah. And he described this SAM, and somewhere 30 years back, he actually gave a honorary lecture in ASC. I think it was probably in Boston. And he said, SAM was described by him, the systolic anti-motion. And he said, why I called it SAM, because SAM is gender neutral. It could be Samantha also and Samuel also, that way. What he wanted to say, it occurs more common both in men and women. But at that time, his explanation was hemodynamic, which means venturi effect produces SAM and causes obstruction. Current theory is it is the less elongated, thickened anterior mitral leaflet and posterior leaflet and elongated cords and abnormally positioned papillary muscle which are responsible for SAM. Not only SAM occurs, but sometimes if the displacement of the anterior mitral leaflet and cord, instead of being anterior and superior, it is posterior and superior, you produce mitral valve prolapse. So both mitral valve prolapse and hypertrophic cardiomyopathy are also described as well as SAM is described. So current theory is little different. The drag is because not a venturi, it's a non-venturi drag of the entire mitral apparatus. and also curvature of the septum plays a role.
So now, when do we say, sir, the LVOT gradient is significant in hypertrophic cardiomyopathy? Dr. Hari wants to know.
So 30 millimeter or more resting gradient is considered significant. Provocable also 30 and more is considered significant. Typically, hypertrophic cardiomyopathy, 1/3 will have resting gradients. In another 40% cases, gradient can be provoked by multiple methods, and induced or resting gradient both are prognostically not good. 30 millimeter is the cutoff.
So there are two questions. I think you need a quick comment from you. What is the meaning of a neutral curvature? And secondly, sir, how do we make assessment of diastolic function in HCM? Is it different than usual heart failure with preserved ejection fraction?
So the diastolic dysfunction actually is no different. It is absolutely same. There is no, the only thing which you need to remember is that in typical hypertrophic cardiomyopathy, the septum, the S prime has multiple fragments, and E prime is severely reduced, and it does not correlate with filling pressure that much. So you can have an E prime in the septum which is 2 centimeter. That does not mean an E to E prime may be 50. That does not mean patient has markedly elevated left atrial pressure. So that is as far as the diastolic function is concerned. Neutral curvature, I think I showed a lot of examples, and where when you see the surface of the margin of the anterior interventricular septum in parasternal long axis view or in a 4-chamber view, and you find that it is absolutely straight. In a 4-chamber view, it is absolutely parallel without any curvature towards the septum, towards the LV. You will call it a neutral curvature interventricular septum. Now, I did show plenty of examples, and I have a lot more examples to show, but the time wouldn't permit it.
I need permission of you, sir, and Indresh to continue asking questions, because I think we are learning more from questions than the lecture.
I have no problem. Go on.
Please, sir. Please go ahead, sir.
All right. All right. Now, the question is that about the myocardial crypts. You know, do they have any significance like we have significance to the LV aneurysm, hypertrophic cardiomyopathy, or otherwise?
So myocardial crypts actually are nothing but blood-filled spaces lined by trabeculae.
Mm-hmm.
They are more common in hypertrophic cardiomyopathy, but they are also seen in hypertensive heart disease. They are also seen even in normal individuals. Statistically, they are more common, but that makes them sensitive but not specific.
True.
And
so there is a request of about Dr. Rohit Tandon wants to know again GLS in hypertrophic cardiomyopathy. You know, as I know that GLS does help, particularly, let me add in Fabry, the hypertrophic segments have a normal GLS, and as compared to, you know, hypertrophic cardiomyopathy where the GLS is abnormal in hypertrophic segment.
Yes. So remember three things. GLS typically in hypertrophic cardiomyopathy is closer to 10%, 10, 11, 9%. In hypertension, it is more like 15%, normally about 20%. Paradoxical strain, which means septum or sometimes the other wall showing systolic stretching or lengthening or positive strain, is highly specific according to Jerome Bex, although we have seen in other conditions also, but its sensitivity is about 54%. And as we publish a paper, if you use color Doppler tissue myocardial imaging, and you do what is called curved anatomical M mode of the entire left ventricle, this variety picks up paradoxical strain in nearly 80% of hypertrophic cardiomyopathy.
We could use occasionally the old technology as well.
Yeah.
Good. Sir, I think I agree with Dr. Adi and would you that we should not call it left ventricle hypertrophy, we should call it left ventricle thickened because it's
Yeah.
actually not hypertrophy. There are so many other causes for that. Is that correct, sir?
Yeah, that's true.
How to say now the mitral valve leaflets are elongated, chordae are elongated. I am adding chorda. Dr. Murugan has asked me that how the mitral valve leaflets are elongated. How do you say, by
So
measurement?
one is a common term. In diastole, if the AML exceeds 20 millimeter, it is elongated. But more than 25 is almost certainly elongated. Similarly, chords are actually again measured in systole. If they exceed 20 millimeter, they are elongated.
Okay.
Chords more than 20, AML more than 20, PML more than 14 millimeter. If they are more than 14 millimeter, it is elongated. Having said that, an absolute value for AML elongation without any doubt will be 25 millimeter or more.
Wonderful, sir. I think the most important question is how do you know so much? Anyway, we'll ask you personally that later on. Now, please explain the physiology behind triphasic mitral inflow. That the kind of L wave you showed, and you said this is very specific for a variety of hypertrophic cardiomyopathy, and how does it is produced?
So the triphasic flow, where between the E and A there is a very prominent L wave. Actually, it is much more than L wave. It is a dome found in actin filament mutation. It is because of delayed relaxation of the left ventricle. Now, the delayed relaxation, normally what happens is that the left ventricle rapidly relaxes in early diastole, and E occurs because of that. After that, the left ventricle relaxation stops and there is no gradient or hardly any gradient between LA and LV, and you don't see any wave. Third is when atrial booster occurs, you see a wave. Here what is happening is because left ventricle continues to relax in mid diastole, the LA pressure has to be high to push the blood into the left ventricle. And the left atrial pressure disproportionately rises to compensate for that incomplete relaxation. And because of that reason, you see this triphasic flow. Triphasic flow is typical of diastolic dysfunction, but it is more often seen in other conditions, non-hypertrophic cardiomyopathy, when there is a relative bradycardia. However, in hypertrophic cardiomyopathy, regardless of heart rate, you would see the triphasic flow.
Yeah, I got I got disconnected in between because of the net connection, and now all the questions have actually on the chat disappeared. So Indresh, I think you would have to do the honor to ask the remaining questions.
Perfect, sir. Perfect, sir. Perfect. I'll go on that. There are tons of compliments is coming. I think there are so many questions are going here and there in the hub. So I think I'll start with this from Dr. Vishal is asking, what is the medical management for the hypertrophic cardiomyopathy? So why have an intermittent syncope in such cases, sir?
Syncope can be arrhythmogenic, can be non-arrhythmogenic. Non-arrhythmogenic simply is because you have produced a gradient, suddenly you produce cerebral hypoperfusion because the blood is not going. Arrhythmogenic is both arrhythmias, atrial and ventricular arrhythmias, common. The people can have VTVF or they can have atrial fibrillation. Holter is absolutely necessary in is a class 1A indication. Every case of hypertrophic cardiomyopathy, people who have non-sustained VT, more ventricular ectopy or sustained VT, they need, of course, an ICD for treatment. Atrial fibrillation people actually need to be put on amiodarone, and so maybe some infrequent unifocal PVCs where other ESC criteria for ICD are not being fulfilled. But the obstruction, if syncope is non-arrhythmogenic, these people need myomectomy or septal ablation.
Perfect, perfect. So there is a request for, can you please explain about paradoxical strain again?
Because of myofiber disarray. Wherever myofiber disarray is maximum, that is a place which behaves paradoxical compared to other segments.
Mm-hmm.
If other segments are shortening and the global and the longitudinal strain is negative, these segments actually get stretched and the longitudinal strain becomes positive here, and vice versa. This is called paradoxical left ventricle strain. Initially described by Ted Abraham in Mayo Clinic, I think he described in 2002, and then was our paper.
Perfect. And so Dr. Om Prakash wants to know, so what's the role of Valsalva maneuver for differentiating between obstructive and non-obstructive hypertrophic cardiomyopathy?
Yeah, Valsalva is one of the maneuvers to provoke gradient. The others can be amyl nitrate, standing position, little bit of exercise. Multiple ways you can provoke a gradient. Valsalva, anything which will reduce the size of the ventricle can provoke a gradient, because you now have to produce a ventriculovalvular disproportion. Ventricle is small, mitral leaflet is big, and it is now causing obstruction. That's the whole funda of provoked gradients.
Perfect, sir. Thank you. Sir, we want to know about caudal SAM.
Yes. So whether it is caudal SAM or anterior mitral leaflet SAM, the mechanism, or even posterior mitral leaflet SAM, the mechanism is same. And the reason is the most of the time the anterior papillary muscle is at 4 o'clock position in short axis. But these people have anterior papillary muscle moving anteriorly and sometimes reaches even at 12 o'clock or 1 o'clock position. Because of the, and also it actually, during contraction it may move. During diastole it may be at 3 o'clock position, and during systole it may be at 12 o'clock position. And because of this reason, the entire subvalvular apparatus and AML gets shifted towards the left ventricular outflow tract, causing caudal SAM or the leaflet SAM. If the leaflets are not lax, then will be caudal SAM. If the leaflets are much more lax, then there will be a leaflet SAM.
Perfect. Perfect. So there's Dr. Sanjeev Bhatt as a case. It was a patient with the hypertrophic obstructive cardiomyopathy presented with the bicuspid aortic valve gradient 90 millimeter mercury. So how to differentiate in this, sir?
So bicuspid valve is common disease, occurs in 1 to 2% population. So there's no reason why it cannot occur along with hypertrophic cardiomyopathy. It is a difficult thing. If you see, of course, SAM and you see marked asymmetric septal hypertrophy, you see paradoxical strain, you see crypts, so you know that their two are combined. But if that is not there, you first have to treat the bicuspid aortic valve and later on realize, is there a residual hypertrophic cardiomyopathy? Whenever you suspect, do genotyping. Number 1, genotyping. Number 2, cardiac MRI. Cardiac MRI has a classic pattern, hypertrophic cardiomyopathy. LGE positive is seen wherever the septum is attached. The RV is attached to the septum at 2 points, anterior and posterior, in short axis.
Perfect, sir. Perfect. So there is one more patient, the case history here. A female patient going for a non-cardiac surgery comes for a pre-operative cardiac clearance, as dehydrated and echo. The septal thickness was 14 millimeter. Gradient across LVOT was 28 millimeter of mercury. Should we label this as HCM?
I think you should repeat the echo in better hemodynamic conditions. Okay. And if still you have hypertrophy, if you think, of course, we have counted nearly 15 points for hypertrophic cardiomyopathy. If most points are being met, it is hypertrophic cardiomyopathy, but if only few points are being met, my suggestion is do a study again with better hemodynamics. And of course, family history is important, hypertension, all that is important. You will be able to reach a conclusion. It's not that difficult actually the real issue is only 1-2% cases. Most of the time we are able to differentiate.
Perfect, sir. Perfect. The next question is about medical management. So, what's your choice of drugs for the regression of the left ventricular hypertrophy, sir?
So I don't use ACE inhibitors. I know Dr. Singh would be unhappy because he has published this paper.
Yeah.
But I use usually beta blockers. They prevent sudden cardiac death, and of course, if there has been non-sustained atrial fibrillation, atrial tachycardias, or there are unifocal PVCs, I will use amiodarone as well. People have used non-hydropyridine calcium channel blockers like diltiazem, verapamil. People have used even drugs like Norpace. They all actually because the negative inotropy, they actually reduce the gradients. But our job is actually they have produced negative inotropy. Unfortunately, diltiazem and verapamil can increase paradoxically the gradient because of vasodilatation. So my choice is beta blockers. I might combine with disopyramide plus beta blocker. Usually I use beta blocker plus amiodarone in case I find on Holter evidence of atrial or ventricular arrhythmia. But remember, think of ICD seriously. There is an app available. It is free. You can use that app to find out whether the patient is candidate for ICD or not. If the wall thickness is more than 30 millimeter ICD, if the patient has apical aneurysm ICD, if the patient has resting gradient more than 30, ICD should be considered. If the LG is positive, think of ICD. Revived or sudden cardiac arrest, think of ICD. Non-sustained VT, frequent grade 4 ventricular atopia on Holter, think of ICD.
Perfect, sir. Perfect. So, Mohammad Rabiul wants to know that if we do have like a normal value of LV wall thickness in Indian population.
Yes. You want to find out what is the normal value of the wall thickness in Indian population?
Yes, sir.
Okay. Can I suggest that I publish a paper in Indian Journal of Medical Research, normal wall thickness in Indians, 50 women and 50 men of all ages, somewhere 30 years back. I would suggest to read that paper. We have recently actually done another study, Manish Bansal, me and Shantanu, which is there in Indian Heart Journal. One can read that paper. That is, I think, in 2017. And we'll be coming out with another normal study, actually, 886 normal individuals, which I think we are trying to get into the ESC in a late-breaking trial. But it would have the wall thickness also. But the wall thickness in Indians is not very different, actually. The left ventricular mass index is somewhat different. It is less by about 5 to 8 gram per meter square, but I am not remembering exact values at the moment.
Perfect. So, which septal pattern of hypertrophy respond to alcohol septal ablation in HCM? Sir?
So obviously, reverse curvature responds much better.
Perfect.
Reverse curvature. Tumor-like, the one which is tumor-like, that responds much better.
Perfect. Perfect. There are tons of compliments are coming, sir. As it was indeed the discussion was almost equal to another presentation level. For interest of time, I'll go for a last couple of questions. Dr. Vishal Mutkula is asking, can we reverse hypertrophy of pheochromocytoma after removing tumor?
Yes, it is reversible after removal of tumor. We have seen it in that lady. I should have presented the care, but the time would not allow. I have a lot of things, but yes, it is reversible.
Perfect.
Thank you.
Thank you very much, and it was a fabulous talk, sir, as usual.
Thank you.
Worth repeating, worth recording. Thank you very much, sir.
Thank you.
Thank you, sir. Have a good day.
All right.